like in a car, they get more symptoms from the visual input. They also find out that stress seems to be an aggravation of symptoms, and this may be common for also other vestibular disorders. So we have decided to integrate this temporal relief and passive motion in the diagnostic guidelines. And we made two suggestions. These are not the real diagnostic guidelines from the Barani, but we made two suggestions to how identify MDDS patients from a motion-triggered onset, adding this feature to the one that my colleague Angelique Van Omberger suggested in 2015. And then the same for the spontaneous, but also with the chance of not having any clear type of disembarkment. However, this indeed is still under discussion, as I mentioned before. The other study that we performed was about a hormone. So again, an online studies. So age and hormonal correlation, we wanted to find out, is it really this perimenopause, menopause, something that renders the patient more predisposed to develop the symptoms? And from what we find out, it seems to be so, because most of the patients, really the onset and the age seems to be peculiar. On the patients that were younger, we also asked if the menses were regular, and we found out that the spontaneous type of patients had a much higher number of irregular menses than the motion triggered. Some also, which is quite interesting, developed the menses during the onset, and some other aspects were like getting off contraceptive exactly when the onset occurred, which again makes us think that maybe MDDS is behaving a little bit like migraine. And so we thought that maybe this estrogen withdrawal theory, where we know that during menses or the premenstrual phase the estrogens are dropping, it could lead to an aggravation of symptoms. And this seems to be the case for MDDS patients. Not sure is because they also have a migraine associated to this, but it seems to be quite relevant for all the female patients that are still in a reproductive age. So what about males? We do have guys, they're not completely excluded. And the guys, seems that, again, from the small preliminary numbers we saw, they also have low testosterone, or they've been taking hormones replacement therapy, like some they used to use steroid drugs. And there seems to maybe also hormonal implication that could affect, in my opinion, the neurotransmitters, maybe the GABAergic system affecting with the multisensory integration. And this could be in this is the theory. Again, for now, it can only remain a theory. One way to maybe also prove this theory and to see how patients are reacting will be with the use of antagonist CGRP, which we know they're very now becoming more and more popular with migraine patients. And the question is, does this theory and treatments also apply for MDDS patients? But again, we don't really know at the moment. Another kind of exam that we wanted to do, kind of test to find out how the hormones plays a role in MDDS patients, was to assess pregnant women. So what we did, we had a similar hypothesis to migraine, and we said, okay, if migraine patients are known to improve symptoms, especially during the first months of pregnancy because of the great increase in progesterone and estrogen. And so we did the same, and we asked how patients felt. Overall, you can see that in gray, the dropping in the sensation of self-perception of motion decreased during the first months of pregnancy. So really pretty much of the patients felt better overall during the first 2 trimesters. And this could be because of the high rate of hormones like estrogens or progesterone, or simply because there is an absence in the cycling fluctuation that usually occurs within every month of the normal menses. Now, quickly back to treatment. So in my studies, one of the treatment that I tested was the optokinetic from the team at Sinai. We wanted to also find out more because they had very different data. They published one paper in 2014 with 70% of success rate. But when they did the follow-up of 1 year, the success rate diminished. So we wanted to find out if there was a sham. So this type of test, we always perform a Fukuda, even if it's not the most reliable test, before to decide in which direction to project the optokinetic. In our case, we had 2 days of sham where the optokinetic was not activated, and then we had 5 days of treatment where the optokinetic was then done. And we also had posturography before and after, and we always kept the frequency of the head roll at fixed 0.165, which seems to be a frequency close to motion sickness. So just to give you a better idea, this is the chamber. The patient has the peripheral full vision completely included. The head is moved right to left at the fixed frequency of 0.165. And usually we do it without any movement of the stripes during the sham. And then during the real treatment, we move the stripe according to the type of fukuda. So this is just to give you an idea of one patient that had the fukuda. You can see that we try to also isolate the noise, but of course, yeah, it's not really the most reliable tool, right? But however, it gave us some indication. We just replicated the protocol of Dye, and that's the deviation that she had during the optokinetic. This is also air. You can see her eyes responding. We always ask them not to follow the optokinetic and to keep stable. This patient improved after years of having this sensation with the optokinetic. This is a typical female patient that she got MDDS after being on a boat. She got off and she got really dizzy, and you can see that in green her posturography completely improved after 5 days of treatment. There is much more to talk about it, but I'm just going to skip some slides. This is just to give you an overview of the results. So we also had similar data with 70% of patients improving of the motion trigger, not of the spontaneous. And we also see that within just 3 days of treatment, they got better. Spontaneous and motion triggered behaved similarly. And you can see here the change in the, this is kind of like in the posturography was really massive for most of the patients. So we do believe that the optokinetic really helps the patient postural stability. However, most patients, they kept retaining other associated symptoms like migraine, like visually induced dizziness, which probably also need other further treatments. There is an interesting case of a patient that after MDDS, we decided to treat for VID, and unfortunately didn't really improve. This is him. I mean, still very, very, very dizzy. As you can see, it's still has no way of where he stands in space, because if you ask him, he says, no, I'm not moving. And then we decided with him to also do neuromodulation, not the TMS, which is another technique used, but the TDCS. TDCS, in this case, we decided to try to reduce also his complaint for migraine by stimulating the V5, which is a known region for the visual cortex, sorry, the V1, which is a known region for the visual cortex, and CZ, you can see one here. And yeah, the patient still has symptoms. Other type of experimental treatment are like gyrostim, which I don't really know what it is. So if any of you has an idea, it would be very interesting to know more about it. And overall, like for concluding, working with MDDS patients is quite challenging because these patients have lost trust in the healthcare professionals since they have visited thousands of doctors, and there is a big psychological component. Also the migraine aspect, and as well as the visual complaint should always be taken into account. So some of the tips is that what we see if the patient receive an early diagnosis is obviously usually have a better outcome. That's also because probably anxiety and other associated level with not knowing what they have, and by thinking they're mad, they just, you know, get better. The hormonal aspect, it's quite important also for the therapeutic options that they're going to be in the futures. If medications don't work, since the optokinetic seems to have no major side effect, is something that I highly recommend, even if it's not always practical to implement. And then eventually other techniques like neuromodulation, if possible, would be really ideal to try with these patients. Just to give you, we also launch guidelines, but what we find out really is the stress component in MDDS. And this is quite important if we consider that stress may also act on the vestibular afferents in the way to prevent the normal compensatory mechanism. So that's probably why certain type of antidepressive or other medication are helping massively these patients. Yeah, we have a lot of questions still about why MDDS patients, they also seem to report a cognitive impairment as well as other. And I hope that the pathophysiology as well as other comorbidity and risk factors are going to be taken into account. But MDDS is quite complex and to study is not easy. So it definitely needs a multidisciplinary approach as well as a consortium of different specialists and also different centers. And hopefully by educating more and more people to recognize these symptoms, we can guarantee early diagnosis to the patient and to improve patient's care. I thank you very much for my collaborators, Shirley Brown, which I work with from Western Sydney University, and Hans Triesman from Holland. That has provided also some of the videos that I showed you. Thank you very much to everyone. And if you have any questions, please feel free to ask.
I have a question, if possible. Dr. Vivian, are you able to hear me?
Yes, I can hear you perfectly.
One of my professors believes, and he always tells us this, he thinks that the mal de débarquement is linked to it's a genetic disorder linked to the X chromosome. What do you think about this thing? Because he always makes us do some a group test that I personally think is not always necessary. I may see some abnormality on the SPV or the rotational chain, but other than that, in my personal opinion, VEMP is normal. Posturography, it's a functional test. It's not a diagnostic test. So what do you think?
Could be. I think I mean MDDS as other disorders. It could well be that there is a genetic component because also there seems to be prevalent in some family line. I heard patients say, yes, my mom suffered from migraine and my mom always had this, but then also, or, you know, there seems to be a familiarity around, but it's hard to say yet. There are no genetic studies on it. Indeed, only functional tests so far. There is no real diagnostic test to find out what that is. And that's why it's so challenging to also identify if this patient really have it or have something else. Not an easy task, but yeah, could well be. I don't know. I think we don't know yet.
Someone is asking, how do you differentially diagnose MDDS with other vestibular disorders subjectively? I think it's the case history, but I'll leave the question to you.
How do you diagnose different these MDDS from others? I guess, I mean, sometimes these patients are confused with, for example, BPD because it's the one that resembles the most the type of diagnostic, right? The really key feature is to try to listen to the patients. If they all say that they get better when they are in passive motion, and they, you know, it's I think I had some cases of patients that they read everything online and they kept saying, no, I have this, but they didn't have this. And it was kind of frightening because you don't know, you can't really have any clear objective type of test at the moment. Unless you have experimental type of examination or studies, like where maybe you have a big control group and you're doing some big studies and then it becomes easier with neuroimaging, but not many people have that at the moment. So it's really also, it is not easy, I agree. There is really functional tests and then asking this question, hopefully they haven't read everything online, like, are you getting better when you are back in motion? And what are your symptoms like? If the patient already start to say, I don't have it all the time, I have it only when I'm stressed, then it's probably not MDDS. MDDS is something that seems to be there on a 24/7 basis. So yeah, but there has to be both trust on both ways, right? It's not easy. Unfortunately, we don't have any clear objective measurements at the moment.
Okay, we have another question. Does the hormonal treatment help?
Hormonal treatments, I had only a few cases where, thank God, during my PhD, I was also collaborating with the gynecology department, and the head of gynecology was amazing in trying to find out. So the first thing he did was always to assess the hormonal status of younger patients. Of course, they still had the menstrual cycle over 2 months. So one during ovulation, one during menses, and try to see how the patient is fluctuating. I think if you have any MDDS patients, if you can collaborate with an expert like a gynecologist, is always better. There are different type of treatment based on estrogens or progesterone or a combination that could help. But it always depends on what the subject is lacking. Like we had cases of female that they were young, but they looked like they were in menopause already. So it's really, yeah, every case in this, yeah.
Okay, we have another question. If you want, you can also read them in the chat.
Yes, so can cognitive behavioral therapy and any form of systematic desensitization be a part of a rehabilitation program? I think, well, yes, but some of the crazy things that I've noticed with these patients is that when the dizziness diminish, also this brain fog, this cognitive constant difficulties that they report seems to also go away. So it seems that this constant background noise of being dizzy doesn't allow them to be able to focus as much. So if you are able to diminish their dizziness, then usually the cognitive aspect seems to be restored. I definitely think the cognitive behavioral therapy in terms of be less anxious, be less on the other side, be less like scared of what's going on and control potential panic attack. That type instead of cognitive behavioral therapy definitely has to be is something that they can benefit from. But pretty much with any vestibular patients, I guess. Okay. Do you think there is a big difference between physiopathology and motion sickness of CD small bark? Yeah, so this is so the motion sickness we ask a lot of patients because at the beginning we thought, is it possible that the MDDS patients are patients that they have a lot of motion sickness in the past, they suffer more from motion sickness. But to be honest, we haven't really found that this is the case 100%, that if you are more susceptible to motion sickness, then you're also more susceptible to MDDS. To be honest, the pathophysiology, if we consider the diet theories, may be similar in terms of the maladaptation of the VR, of this vestibular visual disruption that comes from being exposed to erroneous signals like in motion sickness. But the loop mechanism or the system why these patients become and do not restore to normal, that's different from motion sickness for sure, in my opinion. So what is your protocol for optokinetic stimulation? So you can find more about the protocol I used on Frontiers of Neurology. If you put Mucci, my surname, 2018 sham, then it comes out. And there is actually a table because I try to use a more standardized approach. However, it's quite difficult with the optokinetic in terms that you really have to go with how the patient is feeling. So it's a kind of more like a rehabilitation. You have to see if the patient is oscillating to the left, then you will move the optokinetic always at the opposite side, so to the right side. And you have to see how the patient is reacting to different directions. This is why optokinetic has been criticized so much, because it's really difficult to have a standardized approach with it. And it could well be just a placebo. But from what I've seen, and now that I've also, for example, gave the instruction to other physiotherapists that they are implementing it, and they also get results, I think it does something. It definitely could improve the postural stability of the patient, but I don't know if it's really cured the MDDS. It could just well be just make them more stable. But a lot of the migraine component or other parts that are part of these disorders, sometimes they remain even after the optokinetic stimulation.
Today, and thank everyone for attending. I will definitely, I will see if we're going to post this here on YouTube. Thank you again, Dr. Vivana Mucci. Have a nice day.
Thank you. Bye. Thank